Good evening, everyone, and welcome to our Woo You event with Dr. Joe DeLoach. We're going to discuss billing for AMD services the right way. So I'll be your host tonight, Dr. Ariel Sorenzi. So I'd like to introduce our speaker for tonight. So we've heard from Dr. Caldwell and Dr. Iden on all of the things that we need to know about AMD. And Dr. DeLoach will talk to us about how we can get reimbursed for those services. And he is definitely the expert when it comes to that. His career includes involvement in private practice. He was the medical director of one of the nation's largest optometric referral centers and a former clinical professor at the University of Houston College of Optometry, where he was a director for medical eye care services at clinics providing eye care to over 8,000 indigent patients each year. I was lucky enough to be a student at this clinic, and it was really amazing. They taught us all kinds of great things, and including billing and coding, which we were thankful for. He is noted lecturer on ocular disease, billing and coding, and healthcare compliance, having presented over 3,500 hours in education. He has received every award given to a Texas optometrist, including the coveted Distinguished Service Award and Armistead Teaching Award. Dr. DeLoach is president and CEO of Practice Compliance Solutions, a company providing medical compliance, insurance, billing, record audits, and practice management services. So we're so excited to have you. Thank you so much for sharing your expertise with us tonight.
Well, thanks. I was just excited to hear you introduce me.
Hopefully I did an
Yeah.
okay job.
Oh no, that was great. All right, so let's just get right on with it. You already saw the one disclosure. Here's another disclosure. The bottom line is I really don't have anything to disclose related to this topic or anything we're going to talk about. So we can go on with that. Now, when you present a presentation that has to do with making money, which is not a bad thing, get that right up front. We didn't go to school for 8 or 9 or 10 years to be paupers, and it's perfectly legitimate for us to be reimbursed for our services in an appropriate manner. But we have to do it the right way. So I tend to always start with, let's review the basics of reimbursement. And I do a ton of lecturing on billing and coding. And honestly, I could probably do every one of those lectures in 7 slides because it's the core concepts of billing and coding that you have to understand to really do things the right way. So, what are those core concepts? And really, there's two. And I just threw a third one in because everything we do is based on two core concepts: the reason for the visit and medical necessity. So, we'll talk very briefly about those things. Then there are rules. And I know a lot of lectures get into rules, and we'll talk a little bit about the rules because you should follow them. But we're also going to talk about what do you do when the rules and what you want to do don't coincide with each other. And there are ways to do that appropriately as well. So, reason for the visit. This is literally the core pillar of reimbursement and probably the most misunderstood thing in all of medical reimbursement. And that is that when a patient comes to see you, what you can do for them is not based on what you want to do. It's based on why they came to see you. So if they come to see you and say, my eyes are dry, your job is to evaluate their dry eye. Your job is not to evaluate their AMD. Your job is to address why they came to see you that day. It's a very important concept. As an auditor, which I am, I can tell you that it's so important that if a patient came in and said, hey, my eyes are dry, and your assessment says, AMD, glaucoma suspect, and needs a new pair of glasses, we can and often will deny the whole encounter because literally you didn't do your primary job, which is answer the reason the patient came to see you that day. So it's a very, very important concept. It doesn't matter what you want to do. It only matters what care is involved to answer why the patient came to see you that day. Now, that is the way all of medicine works. This is not optometry. This is medical reimbursement. And anybody that's, everyone goes to their MD, DO, PA, whatever for general medical care. And that's the way it happens. They'd see you for why you came to see them today. Now, specific to AMD presentations, how does the reimbursement, how does the reason for the visit work? Well, if this is an initial visit, then you can't go firing off on AMD unless the patient presents with some symptom that would be related to AMD. Blurred vision, metamorphopsia, light adaptation. We're going to talk specifically about those things a little bit later. But if you have no symptoms, but you look inside and there's the drusen, you can bill tests related to that finding. You can't bill the office visit under the diagnosis of AMD, but you can bill tests. And that's the way a lot of our colleagues like to do it, but I will contend it's not the best way. Reimbursement, when you are dealing with primary care and medical care, really are oil and water, and they don't mix. And it's just like going to your, physician or PA for a physical. I mean, they go in and they say, okay, Joe, your blood pressure's a little high, and I heard this little funny thing in your heart. You don't go check into the hospital that day and have a bunch of cardiac tests run on you. They say, we're going to schedule you back and evaluate this problem. That's really the way to do it. It avoids lots of problems. And to be honest with you, if you do everything correctly, then you can say, how do I make more money? You make more money if you don't mix oil and water. All right. What if it's an established patient? Well, then it's home free, because now the reason for the visit typically is going to be, I'm having you come back to evaluate and manage your glaucoma, but in this case, macular degeneration. But it is very important to say the right things. Now, I'm going to get very picky in advising you what to put for the reason for the visit, because it will make an auditor smile. And if you want to start off good in an audit, you want an auditor that goes, they know what they're doing. I don't need to worry about this doctor so much. So directive language is very important. So if the patient's coming in for a follow-up because you want to, follow up with their macular degeneration, the literally best words to put down are physician-directed evaluation of macular degeneration. That's called directed language. You are literally directing the evaluation, in this case, related to macular degeneration. Now, you can have other reasons that they're there. So we're kind of talking about, this is just a specific follow-up for macular degeneration. If you're going to run tests, this is a great place to put orders, because all your testing has to have an order behind it to establish medical necessity. So it's very easy. Physician-directed evaluation, macular degeneration. Today, I am ordering a retinal OCT and dark adaptometry. Now you have established the necessity for conducting those two tests. And later on, as you know, you have to have an interpretation report for all the tests that you run. Reason for the visit is very straightforward. Just have to grasp the concept. Then we have medical necessity, the second big pillar of reimbursement. And this one's just really easy. It's just, what do I need to do to take care of why the patient came to see me today? Nothing more, nothing less. It literally dictates the necessity, quote unquote, of the service component, which is our office visit, and any additional testing that we want to do. Now, here's where you really have to, and I'm going to say this many times over and over in the next 50 minutes. What you determine to be medically necessary and what the patient's insurance is going to pay for oftentimes do not coincide. Now, again, if you've been to your MD or PA or whatever, and they decided to do all these things and said, Joe, I'm going to run this test and run this test, believe me, they don't go check to see if your insurance pays for it. You're going to get to check out and say, okay, today you had these tests. They're not covered by your insurance. Will that be cash, check, or credit card, or your firstborn? That's literally the way checkout works. So the concept of we only want to do things or only consider doing things because insurance will reimburse for it is totally off base. As a matter of fact, later on, I'll make the statement that the more things I can do in my practice that aren't covered by the patient's insurance, the better off I am. I don't have to follow a bunch of rules. I do what I think's best for the patient, and they pay me at checkout, and the money goes in the bank today. No insurance form, no nothing. That's nirvana. So the drive to only do insurance approved procedures and testing is a little bit off base. So there are definitions. There are many definitions. If you pull out your Blue Cross Blue Shield provider manual or go to CMS, they all have a definition of medical necessity, but it's really pretty easy. You just stop for a minute and think, is what I'm getting ready to do going to influence my care of this patient in some way? Or am I just running a test because I can? And I don't mean that to be, as harsh as it sounds, but that's oftentimes, unfortunately, what happens. I know I can run this test, but is it really necessary that I run the tests? This is what leads to one of the biggest problems that optometrists fall into in major audits is what we call lack of confirmatory testing. So they're violating what's called the confirmatory testing rule. So the italics are right out of CMS, right out of the provider manual. And I'll just summarize it for you. It says that you can't just run a bunch of tests. You can't have a patient come in and go, I'm going to do these 5 things today. Because the confirmatory testing rule says every time you make a decision to run a test, it must be based on the knowledge and information you have prior to running that test. So I run a test. Do I have the answer yet? No, I do not. I need more information. I may now go run another test. Do I have the information I need? Yes. Stop. No more testing. The confirmatory testing is that old adage of once you hit oil, you stop digging. You cannot continue to run additional testing to confirm what you already know. And I can tell you from an audit standpoint, this is a major problem. So this is what we see. And of course, I made this up. But if you're doing this in your practice, please stop. We call it panel testing. So this is my protocol for a patient with AMD or glaucoma or whatever it is. And the point is, you can't have these protocols because you can't establish medical necessity for all these tests in advance in many cases. And the number one being photography. And we'll talk about that in just a little bit. So these kinds of protocols in offices are a wonderful way to have a very adverse meeting with one of the evil auditors. So are they that evil? They're not evil, but they do have a job to do. And the government's very active. During COVID, they told us, we're not going to audit you. We're going to let you slide. You got bigger problems. That's all gone. CMS had a statement that came out with that said the audits will increase in full force despite any continued pandemic. And why is that? Auditing is incredibly valuable and puts a lot of money in insurance companies' pockets. So they are really going after it. I want to tell you one thing about the data initiative project team. This is new. And we knew this is coming. This was called predictive analysis for years, but now they have it. And so now the way I audit records for companies is I look at your medical record and I look at all the documentation and blah, blah. It's all going to be done now on artificial intelligence. It's all going to be predictive algorithm analysis. And literally they will go, I see that you're claiming that you want to be paid for these things, but based on our artificial intelligence analysis, we don't think that's necessary. So we're not going to pay you for this. And you have to prove to us why you think you should get paid. So another reason you just really need to do things correctly the first time. All right. So billing and coding really is one slide, in my opinion. It's all medical ethics, and it's just do what's right for the patient, and you don't have to worry about breaking rules, and you don't have to worry about making money, because our system is set up for us to have a wonderful living just doing things the right way and taking care of our patients the way we should. Okay, lecture over. Now let's get directly to AMD and how do we do things the right way. So I I took everything I could think of that you could possibly think about doing with an AMD patient. And I know Greg and them have talked about this, and I'm not going to get into theory of these. We're going to get into, can you get paid? Should you get paid? How do you get paid on these things? Now, comments I will make on this are based on preferred practice patterns, predominantly from the American Academy of Ophthalmology, Medicare Advisor medical policy, which addresses most of these issues, recent policy decisions. I will throw in some subjective opinion, but I'll let you know when I do that. So we're going to go through high value things, maybe things, and then what I call, the really low value things. So it's interesting, but with AMD, your direct observation is still paramount for early diagnosis. I mean, that is key. Now we're going to talk about technology that will help us predict, which is going to be incredibly valuable. But as far as making the diagnosis that the disease is present based on physical findings, your eyeballs are the key. Now, we'll talk about photography in a minute, but I just want to get that down, that is still the core. So there's a lot of things we can do from a screening standpoint. And here I'm going to say it again. Tests that are not deemed to be medically necessary does not mean they're not valuable. And it doesn't mean that you shouldn't run them nor be paid for them. It just means that an insurance company or some panel has decided that they don't want to pay for this. And sometimes it's not based on whether it's good or bad. It's based on a whole bunch of other stuff. So screening tests are wonderful, and we'll talk quite a bit about them. But we do need to talk about photography. So in many policies coming out, you're going to hear the statement that photography is not medically necessary if the information is shown in better form and higher technology. Now, what does that mean? It means that just clicking off a photo to show that there's drusen may not be medically necessary when you're sitting there looking at an OCT and actually looking at drusen at a microscopic level. Now, I'm not saying you can't do both of those things, but we are going to talk about the rules of photography. And when you have to establish the medical necessity of a test, you have to meet that definition. So by definition, taking a photo of nothing is never medically necessary. There are a few exceptions to this in very few payors, but taking a picture of nothing to document nothing is not medically necessary, because in your medical record, you've already said nothing is there. Taking a photo does not benefit the patient in any way, shape, form, or fashion. You can also not repeat the same photo over and over. So it is of no value to show that it's exactly the same when your medical record says nothing has changed. So those are two hardcore rules that you need to follow. That is exactly why I said fundus photos can never be ordered ahead of time, because you don't know if there's something new to take a picture of until you look. And once you looked, you can order a photo to document that change, but you never know before you see the patient if you need a photo. So let's go to OCT. Now, they are essential. I think they're extremely valuable more in the moderate to advanced disease. I get a little cynical sometimes with some of this, and it's like, I run my OCT. I looked in there and there's some drusen, and I do an OCT and oops, there's a bump. Well, yep, there's a bump. So in the early stages, I don't think most people feel that OCT is dramatically valuable in the overall picture. But it doesn't mean it's not, and it doesn't mean you shouldn't do it. We have new technology that I'm sure they've talked about with OCT angiography, which is going to be very beneficial more as the disease advances. And you certainly, if you have that technology, it's quite interesting. This comes up all the time. Why can I not take a photo and do an OCT at the same time? And all I can tell you is every time you see some answer to this on a blog, just close your eyes and act like it didn't happen, because they are literally the worst source of information on billing and coding on the planet, because most all the information is based on one evil concept, which is I got paid. And it doesn't really matter if you got paid when the auditor comes and takes all the money away. So there is an edit, an NCCI edit, that says you cannot do a photo and an OCT at the same time. It's a rule. And it says that the 59 modifier is an inappropriate tool to override an NCCI edit. You can follow all this stuff on the blogs about put down 2 different diagnoses and all this stuff. It's going to get denied in audit every single time. Now, having said that, I'll tell you something maybe you've never heard before. This is new. So there is one carrier in Medicare called First Coast. So if you're listening and you're in Florida, you know who First Coast is. First Coast is very unique because they are the baddest carrier. I mean, they are the big dog. It's interesting. First Coast only manages one state, and that's Florida. So you can draw your conclusions why. But they have kind of been charged as being the carrier that develops the really stringent, hardcore properties on this stuff. And so they actually came up with this policy here recently, and it just blew everybody away, because they said that they feel it can be appropriate to take an OCT and a fundus photo on the same day for the diagnosis of AMD. Now, they have a specific list, and there's no glaucoma on that list. As a matter of fact, there's very few things on the list, but AMD is on the list. Now, they do say that your medical record must justify your decision to do that. So in your interpretation report, you're going to have to explain why you needed both pieces of information. And you are allowed to use the 59 modifier, and it's actually the XU modifier to do that. Now, this is specific right now to First Coast. This does not mean that other carriers have to adopt this policy. But in general, a lot of carriers follow First Coast's lead. Do not think this means that Blue Cross thinks this as well, or any other medical payer for that matter. So if you decide to do this, okay, expect to be audited. And that means your medical record must uphold your decision. Now, let me just say one thing about that. If you decide that it's important to do something, these rules can be overridden if you can make an argument of medical necessity. And that argument has to be in the medical record. So if you want to push the envelope a little bit and do both these tests at the same time, you better have stellar documentation in your medical record to justify why you made that decision. I like to avoid that kind of stuff. It's just too easy to not do them both on the same day. I'm going to have the patient back another visit. I can do one test one time and one the other, and just avoid all this angst. Now, there is a national Medicare policy on OCT. And it literally states that they think it's a very valuable test, especially with central vision disorders. And it sets the kind of usage statement of, we don't think you would do more than one every 2 months. Now, when you read that, you probably are going, really? One every 2 months? Be very, very careful. You're going to have to justify why you need one every 2 months. In an initial or early AMD, that's going to be pretty hard to justify. As the disease gets worse or is demonstrating progression, that would be a reasonable thing, as long as you're documenting that correctly. Now, here's an unfortunate thing, and why some people think I try to stop people from doing testing, and that's exactly wrong. We under test, or let's say a large segment of our colleagues under test for whatever reasons. But because of that, when you are audited in a lot of payers, you are judged against your peers. And I'll tell you that the national average for retinal OCT And this is for, all patient visits. And optometry is 8%. So our colleagues on the average do an OCT on 8 out of 100 patient encounters. And that's not a lot. That's not a lot at all. I can tell you that the ophthalmology number is multiples of that 8%. So we have some people that are pushing the envelope, but unfortunately a lot of folks are really not doing as much as they can or should being the operative word. All right, let's move on to dark adaptation. So this is a really interesting one. You heard what it does and why it does it, and you probably heard the studies of how it predicts the presence of the disease long before we can see it with the fanciest OCT on the planet, and oftentimes well in advance. And it's got a very high sensitivity and specificity factor. It's a wonderful test for AMD. This I think is really interesting. I think glaucoma, I can tell you that inside optometry, glaucoma is the most over-tested disease that we encounter. And AMD is 4 times more prevalent than glaucoma. And vision loss from AMD is multiples of glaucoma. As a matter of fact, most people with glaucoma never lose real functional vision. And there's no test to predict who can get glaucoma. The only thing we can do with those folks is see them over and over and over and over and over and see if anything changes. But we have a viable, proven test to predict who is in early stage AMD. I would also probably make the statement that I think the public, and especially your maybe over 45, 50, 55 patients, they've heard of and especially fear AMD far more than they do glaucoma. So from a taking care of patients and having them buy into the types of care you can deliver and the type of testing you can do, I contend it's much easier for this disease because they know about it and they know grandma lost her vision from it. So how do you do it? Well, look, this is real verifiable science. And I could just go on and on and on with this. And so why has it not caught on? Even though we've had clinical instruments to do this in the past, why is it not caught on? And we've talked about this, and I think that one of the main reasons was it was a bulky instrument. It got smaller. It was very expensive. And I'm just not sure that the marketing really told us how to present this to our patients in a way that they got the dramatic necessity of screening for this disease. That has all changed. And later on, I think you'll hear that technology now makes this far easier for far less money. So I think our kind of second generation of AMD and dark adaptation testing should be revolutionary in my humble opinion. So you can still do this from a screening standpoint or from a diagnostic. And I really can't emphasize the screening enough for 2 reasons. Number one, remember, dark adaptometry is designed to detect the disease before we can find it any other way. That's a beautiful screening situation. So a lot of people establish their hit list. I mean, what are my screening protocols? And you can make your own. You can talk to your colleagues. You can talk to the companies dealing with this kind of technology, and you can pretty much establish, who would I offer this to as a screening test, knowing I tell them I have it. It's no different than I have an instrument that'll take a big old wide field image of your retina, and here's the value of that. Same thing here, although I will contend that patients can see the value of a screening test to detect something that will make them lose their vision far more than just what I think is a wonderful technology, but just a fancy picture. All right, Optos will slap me silly for saying that. I put down, what I have encountered people are charging for this from a screening standpoint. In no way am I telling you what to charge. I've just kind of given you ideas of what your colleagues are doing. and they just do that as part of their routine exam every year. Now, now we can get into the diagnostic protocols with a established CPT code for this. But here's where we have to talk about details of how you can do this properly and get paid properly. There are not a large number of diagnoses that will be reimbursed, and particularly in CMS. And they're pretty much right there on the screen. And that's not a lot. So you notice that there's not a diagnosis code for macular degeneration, and there's not. So we're really basing it on the kinds of symptoms that may be indicative of AMD, but I'm going to tell you how to take that a step further in just a minute. So I said I'd talk about the American Academy of Ophthalmology. They really have no protocol for dark adaptometry, dark adaptation, so really can't address that at all. It is a reimbursable procedure under Medicare and under many medical payors. I can tell you the Medicare average is around $60 because that's not fee setting. You, of course, would establish your own fees for what you think is appropriate. Now, this is where it really works really well. Let me go back, and you see that blue statement because you see one of the applicable diagnoses is dark adaptation abnormality. So how do you know if someone has a dark adaptation abnormality? You run a test and you get a dark adaptation abnormality. So the screening test drives the diagnostic test in a major way. Now, this is just a really, cool way to look at this, because when you're talking about really valid screening things, it is great care for your patient and great for the practice, the bottom line. That's a win-win. It's an ethical winning combination, as I call it. And when you can have, revenue increase that's the result of ethical, good quality medicine, it just doesn't get any better than that. So, and this absolutely falls into that category. So I told you I'd talk to you about the symptoms. So do not put in your record that Joe is here and says, I'm having trouble seeing at night, or Joe has reduced night vision. I can tell you that in audit circles, those are not considered synonymous terms with night blindness, which the CPT, the ICD code, right, was night blindness, not problem seeing at night. So I would be far more specific if I'm trying to establish medical necessity based on the reason for the visit. And I gave you some examples. Loss of vision after passing a car with bright headlights. Can't see or function safely in dimly lit areas. And you're like, now I have to hit the keyboard more. And the answer is yes. Do you want to keep the money when the auditor leaves? You've got to establish more than just a statement of, I have trouble seeing at night. It won't pass muster in most cases. Now, I don't want you to ever put words in your patient's mouth, but I can tell you, as being an older citizen, older folks have trouble with lights. And all you have to do is make sure you quiz them appropriately. You don't put words in their mouth, but older folks have problems with lights. So you can set up your screening questions or make sure your technicians are properly quizzing them. But most of the time, you're going to come up with the appropriate symptoms that will allow you to take care of your patients in the proper way. Contrast sensitivity. I don't even know if they talked about this one. Maybe they did. It's been around forever. This is a quantifiable test for AMD. The research has been done. We have reduced contrast sensitivity, and the acuity has not changed whatsoever. So it really is another great test. So where's the hang up? Well, the hang up has been because we have really no easy quantifiable test for contrast sensitivity until now, but we do now. And maybe you'll hear about that a little bit later on. Now, there's no CPT code for contrast sensitivity. So this you would have to consider to be a screening. You can consider it a diagnostic test as well. But how do you bill this? Well, you do not bill it as an unlisted diagnostic procedure, because CMS has put in writing that they consider it to be part of the comprehensive evaluation. So you can't really break it out. You can bill it to a medical test that your patient pays for. Remember, just because the insurance company says I won't pay for it doesn't mean it's not valuable, doesn't mean someone should be paying you for it. And obviously you can bill it as a screening test along with your dark adaptation screening, along with your OCT photos, all these things that can be, better care for an additional fee. Or I've even had people that just wrap all this into a much higher exam fee and go from there. However you want to do it, these are great things to do for your patient. All right. And I think I just said all that. I do not want to leave any impression that anything I'm saying is not valid care. As a matter of fact, everything I've talked about so far is in that high level, the high, important, valuable listing from that slide I showed you. We hadn't even got into the questionable stuff yet. So all of the things we've talked about so far, I would strongly consider to be part of the regimen. And as I said, there are very nice ways to do all of this testing, much easier than it used to be. All right, let's talk about visual fields. There are 3 of them, so we'll kind of wrap them all together. The first is called a preferential hyperacuity perimetry. This has been around forever. It was originally designed to detect the conversion from dry to wet AMD, and it does it in an exceptional manner, far more than our silly Amsler Grid test that I'll talk about in a minute. The problem with preferential hyperacuity for a long time as an office test was membranes develop very quickly. And if you could be seeing these patients every 3 months, and they would develop a massive membrane from the last time you saw them, and you missed it. So the company that makes this found out a long time ago, we're going to have to develop a home unit, something that they can literally get up and do every day, and instead of looking at a silly Amsler grid, and it will actually give you very accurate, very quantifiable results. And that is available. And I won't get into how that, again, this is typically, difficult to bill. It is possible, but the companies that make this stuff can tell you all about how that works. You can still just basically do a central visual field. Now, the problem here is where it may be valuable information from a reimbursement standpoint. Most all the policies related to doing central visual field testing state that it is not applicable until the acuity drops to a horrible level, probably to a level that the central vision test is not very accurate anyway. So this becomes a problem. I will leave it in as a valuable test because sometimes when you have comorbidities, when you look at their subjective visual field response versus their OCT versus whatever, their slit lamp exam, you can get a better handle of where the problem really might be coming from. So it's still a valuable test, and I wouldn't throw it out. This is the one I'd love to see thrown out. The studies on this get comical, to be perfectly honest with you. The average detection, when they've done a bunch of studies, the average detection of a change in the retina due to AMD with an Amsler grid is at an acuity level of about 2070. They're way in trouble at that point. They actually compared that to just giving them a Snellen chart to look at, and it was almost twice as sensitive as the Amsler grid. So maybe we should be sending people home with a little Snellen chart as opposed to an Amsler grid. It's not a billable test, and so why do people still do it? And it's one of the examples of a lot of things I call dogma. Dogma is something that you just keep doing and we don't even know why. We've done it this way forever. There's not a lot of reason to do it, but we're going to keep doing it just because that's what we do. That's dogma at its best. So I'm not telling you to not do it because it has hung on as this goofy standard of care issue for a long time. But honestly, don't expect your patients to come waving their Amsler Grid at you going, I see squiggles. So how do you bill these things? Well, a 10-2 full threshold is still a 92083, but remember there are limitations on when that would be billable under carrier guidelines. Hyperacuity perimetry, as I said, in office, it's considered a level 1 or 2. It's actually a level 2. I don't know why some people consider it a 1. And the remote is actually a level 3 CPT code. But again, go to the company that makes these and they can tell you exactly how to appropriate be bill for this. Well, what about fundus autofluorescence? I kind of downplayed photography, and I did. But if you're going to snap a picture, most of our cameras, especially a lot of our modern cameras now, will do autofluorescence. Well, autofluorescence in the evaluation of AMD is dramatically valuable, and I don't know how much they talked about that in the other 2 sessions, but just snapping a picture of a colored retina versus what you see with autofluorescence is night and day. And so autofluorescence is far more valuable than fundus photography. Well, how do you bill it? Well, years ago, fundus autofluorescence was classified as nothing more than a fundus photo. So it is a 92250. You can't bill it as an unlisted procedure or any of those kind of shenanigans. It is a fundus photo. But it is different because a fundus photo is not diagnostic. A fundus photo just documents. Autofluorescence is diagnostic, just like an OCT is diagnostic, like a visual field is diagnostic. So was it rational for them to say these are the same thing? And the answer is no way, no way. It was crazy for them to do that, but it was nothing more than a financial decision. So can you bill autofluorescence as a diagnostic tool? And the answer is yes, but you will still use the 92250 code. So here I've had this asked, well, can I do a fundus photo and bill it as a fundus photo and then autofluorescence because I'm doing 2 different things? And the answer is on the same visit, you cannot, because the rules are you can only do 1 photo per encounter. So that will not fly whatsoever. But remember the photo rules. The photo rule says you can't take a picture of nothing, and you can't take more pictures until something changes. Those do not apply to autofluorescence because when you snap the picture of nothing, you know exactly what you're getting. When you snap a picture, convert it to autofluorescence, you have no idea what you're going to see until you do it. Just like an OCT, just like a visual field. So autofluorescence, even though it's the same code, is a true diagnostic test and doesn't really follow the rules. Document that correctly in the medical record and you will retain your money. I can talk about genetic testing real fast just by doing this. There's really no test to say I'm going to get macular degeneration. Will there be? Most likely, yes. I mean, we are dissecting the human genome at amazing levels, and it would not surprise me very shortly if we have that ability to do that, but we do not, and we certainly do not have the ability to do that clinically. And the carriers say the same thing, and the research says the same thing. It's very limited. There's no consensus. The information we have is not very scientific. Even the information that says, oh, well, you may want to do this because it's going to identify those folks where they should or should not be taking zinc in their formula, even they have gone in and said that was wrong. As a matter of fact, you can see that this one said they found errors in the analysis, and it really doesn't support the test even for that. So again, you have to make your own decisions based on what you understand out of research. But if you do that research, you'll find that genetic testing just isn't quite there yet. But it's really easy because it's not reimbursed. So if you do it, it's out of the patient's pocket. And every single carrier on the planet, and many of them specifically state that genetic testing for macular degeneration is considered not investigational and not medically necessary. So if you want to do it, absolutely, that comes out of the patient's pocket. What about carotenoid testing? This is relatively new. We've been able to do this with a blood draw forever, so it's really not new from that standpoint. But there's some new instruments now, some non-invasive ways to measure your carotenoid levels. And I bet you they talked about these if you were on the other programs. I'm going to throw in a couple of caveats on this one, just from my study of it and my opinion. The statement that if your carotenoid skin levels are down, that represents down at the retinal level. There's some research behind that, not enough to blow my top off yet. Maybe more will come. We know carotenoids are invaluable to the macula, but I think we're going to have to learn some more about this. I'll also, throw in one thing I found in watching this, and it's as a screening test, almost everybody you test is deficient. And that makes me ponder for just a minute. And just from my personal opinion standpoint, I'm not as keen on tests that are tied to some proprietary product. It just doesn't set as well. It's not to say they're bad products. I think they actually are very good products. And I think they probably are very good for early stage. When you get into the advanced stages of AMD, and I'm sure Greg talked about this, there's way more you need to be thinking of than some ARIDS formula or modification of it. But as I said, if you were lucky enough to listen to Greg, I'm sure he covered that already. So no CPT, no coverage. It's screening totally. Or, and I'll talk about this at the end, it may be, you might want to consider this as part of your lifestyle counseling, which we'll talk about in a minute. I can bust through MPODs. I know probably a bunch of people listening are still doing MPODs. Read the literature. There's hardly any science behind them whatsoever. Never has been. They're not worthless. I don't want to say that, but just read the literature. I mean, I can show you this stuff all night long about not valid, go on and on and on. The National Institute of Health has said very little, test retest validity. Validity and reliability aren't there, and the significance is really unknown. So you have to determine for yourself if you believe in MPOD testing, and I wouldn't say throw it in the garbage, but do some research, and if you're still convinced, certainly do it. There's no CPT for it, so this is another screening out of the patient's pocket. Now, this is the last thing I want to cover very quickly, and that is, are there other ways you can help people with macular degeneration besides running tests and giving them some nutraceuticals? Because we know the evidence is there to say that there are strong factors that make you more at risk, whether they be poor dietary factors, poor lifestyle decisions, our couch potato syndrome, obesity. All of these things increase your risk for macular degeneration and a host of other things as well. So is it time maybe we incorporate lifestyle counseling from an optometric standpoint? Well, nobody else is doing it. I bet you can't walk into an ophthalmologist anywhere on the planet, much less a retinal specialist, who's going to sit down and say, you know what? You may need to lose some weight. You may need to change your diet. You may need to move it more often. You may need to do these things. They're going to make you a healthier person because it's going to make your eye healthier as well. Now, okay, that's fine. Can I get paid for it? And that's the question. Well, we don't always do things just to get paid, but what I'm here to tell you is you can. So there are counseling CPT codes, and one of them definitely does not apply because in the descriptor, it specifically says this is a dietary specialist. So if you have that designation as well, it can work for you. The other two are debatable, the 97802 and the 97803. There is one carrier that states that this is also limited to dietitians, but it's the only one that does. The other thing about these is most major medical carriers, this is not even on their radar yet. So you can file these things, maybe even appropriately, but you may hit a roadblock. But there's another way. When they redid the evaluation and management codes in 2021, they opened the door to far more application of the evaluation management codes. And so if you don't understand how to use those codes, please do. You can contact me and I can give you, easy to understand spreadsheets on how it was changed and how to use these codes appropriately. But you can actually have counseling sessions with your patient. You never put a slit lamp in front of them, and you can meet the requirements of evaluation management codes. You can definitely do it based on time as the sole factor in determining the code. So, this would be a whole hour how to do this. But if you're interested in incorporating lifestyle counseling, do not think that you can't get paid for it, because you absolutely can. So, summary. We need to manage this disease at a very high level. To me, this is just like glaucoma. We should own the disease of glaucoma. We should own the disease of macular degeneration until such time as the appropriate intervention is beyond our scope, but not before. There is way, way more to this disease than just looking at drusen and sticking needles in people's eyes. And I say that facetiously, but that seems to be the focus, instead of, can we find ways to prevent and slow, as opposed to the billions of dollars being spent just on things that are a band-aid, essentially. And there's a lot more options for how you can care. And I hope that's what we covered in the last almost exactly 50 minutes. So that's my last slide. So I will turn it back. Actually, I'll keep going on the slides, but I know someone else is going to talk at this point.
Yeah, man, that was good. Right on the dot. So awesome presentation. We have a lot of doctors that just really praised how great of a presentation this was, how insightful it was. And so thank you guys. Thank you for sharing that with Dr. DeLoach.